Very good afternoon, and thanks to Dr. Vitull for organizing such a fabulous meeting. We had a very good talk on eggs and diet, and all this is basically for prevention of heart disease. Now moving from prevention to treatment of heart disease, and one of the most important, I would say, invention and controversial also procedure is coronary angioplasty, which has come up as a treatment, as probably the most effective, most less invasive treatment of coronary artery disease. So this procedure came, I'll just be talking about when it came up and how we are different from what we were say 20 years ago and how this procedure has evolved. So this procedure came up in 70s, and I would just, I had mentioned this thing to highlight what we were before this procedure came up. So imagine in 1955, while the American president, playing a round of golf, had chest pain, and he was diagnosed as having heart attack. And imagine the treatment was, he was put on oxygen, on nitrates, heparin, morphine, and that was it. And he was in hospital, waiting for his pain to be relieved, and not knowing when he'll be well, or whether he would survive or not, or he would continue as being the president. So that was the kind of predicament, I would say, of coronary artery disease in 1955. Even the American president, the most powerful person, didn't know what would happen to him after a heart attack. Now this legend, this guy, Gruenzig, he was the first person to start angioplasty. He did the first balloon angioplasty on a 35-year male who had a heart attack, survived the heart attack, and he had a angioplasty done to his, balloon angioplasty only, done to his proximal LAD in 77 years. And I think he was still alive about 10 years back. So just with this single balloon angioplasty, Gruenzig, transformed the, the whole scenario of cardiology from being a diagnostic discipline to the subject what we call as interventional cardiology today. So he transformed the entire scenario, and these were some of the other gentlemen who helped him in achieving this, start of this procedure, like Mr. Sohns, Seldinger, Daughter. All these, majority of these doctors, they were, they were radiologists, interventional radiologists, who started doing balloon angioplasty in the peripheral vessels. But Gruenzig was the first guy who started doing balloon angioplasty in human coronaries, which was considered actually blasphemy in those days. It was forbidden to even touch coronary artery. Even doing an angiography in human coronary happened by chance, because it was thought if you touch coronaries, the patient will die. So in 60s, I think early 60s, by 65, a bypass surgery came up as a treatment of heart attack or coronary artery disease. And in 77, Gruenzig started balloon angioplasty for people having single proximal diseases, simple diseases, and for treating their angina. So balloon angioplasty started, and slowly it evolved with better hardware. We were able to do more and more lesions, open up them with balloons, but then there were problems. This procedure was suboptimal because almost 10 to 15% people would have re-blockages even in the hospital. So in the hospital they would have acute re-occlusion of these arteries after the procedure and would have to be sent for emergency bypass surgery. So that was the bane of balloon angioplasty. And almost 30 to 50%, I would say, restenosis in the next 6 months. So after next 6 months, they would require another procedure, either again a balloon angioplasty or maybe a bypass surgery. So, with invention, this angioplasty not only brought in a new procedure, but also opened people's minds, brought in a revolution of investigations, innovations. And in 87, these, in France and in, I think, Sigwart in Switzerland, they came up with metal scaffolds called stents. So these were basically steel stents. They were bare metal stents developed with steel, which after balloon angioplasty we would deploy in the coronary artery. The main advantage being the prevention of acute reclosure. They would prevent that acute reclosure 10 to 15% which happened in the hospital. And subsequently, the trials showed there was almost 20 to 30% reduction in the 6 month restenosis also. So these bare metal stents brought in the benefit of prevention of reocclusion, and second was, of course, the restenosis also reduced, but still there was very significant, almost 20 to 30% restenosis. Mechanism being, of course, there was neointimal hyperplasia happening within the metal stents, and second was the problem with stent thrombosis, being a metal inside the coronary artery. This metal made us prone to have thrombus formation within the stents, and this stent thrombosis happened almost in 10 to 20% people. So 10 to 20% people having stent thrombosis in the era when only we had aspirin as an antiplatelet agent. So, and we need to understand that stent thrombosis actually killed. Stent thrombosis even today carries a mortality of 30 to 40%. So after this era of bare metal stents, again it was found to be suboptimal. People were planning and new things were coming up. So the biggest revolution after bare metal stents came in the form of drug-eluting stent. So drug-eluting stent till today, it is the standard of treatment of care of coronary artery disease, and of course with a lot of refinements occurring after 80s. It came in late 80s. And then there were refinements carried out in the structure of stents. They were made thinner. They were made of thinner material, thinner but more hardy material in the form of alloys of cobalt and platinum. And third refinements came in the antiplatelet therapy, when we understood that to keep blood flowing in the coronaries with stents there, we need blood to be thinner and we need better antiplatelet agents. So drug-eluting stents was the first experiment where biotechnology came in the aid of medical science, where we had a platform, a stent delivery platform with the metal, and we had a drug coated and we had a polymer over which the drug was coated, so that the release was slow. It was not released immediately, it was slowly released. And what were the drugs? They were basically anti-proliferative, or drugs being used for cancers. So these were the drugs which were used, and this was due to the polymer, they were slowly released. And basic aim was to prevent the restenosis which happened over 6 to 8 months. So the first generation stent were very renowned, Cypher and Texas stents. They were put in the patients, and the trials were amazing. There was 0% restenosis rate in some of the trials, even after 1 year. There was no restenosis. That was the kind of results which were seen. And after 5 years, the restenosis rate was still very low, usually in single or double digits, say 10 to 12%. That was the kind of result with the first generation drug-eluting stents, but the problem was still there. The problem was that whenever you tend to stop this antiplatelet therapy due to whatever reason, somebody required a surgery, somebody had a bleed, and you required to stop this antiplatelets, these stents would have thrombosis even after a period of say 4, 5, 10 years. Whereas with bare metal stents, you normally didn't see thrombosis say after a couple of years. So that was the bane of this drug-eluting stents, because probably delayed healing. They had those drugs which released and prevent proper healing inside the coronary arteries. So this drug-eluting stent, of course, brought in decreased restenosis, but some very late stent restenosis did occur, and there was stent thrombosis. Then came the second generation stent, where we had again thinner studs used for making stents, and there were different better drugs which were coated on the stents, and the results were for everybody to see. These new technology, the main feature was these were more biocompatible drugs, and the polymer used was biodegradable, where it would dissolve with time, and that's why the results were so good. And these second generation stents were almost 50% better results than the first generation stent, and these stents are still being used today because the results were amazing. The kind of restenosis or stent thrombosis which we received with these stents actually is as good as just putting a bare metal stent. So, and it is still being accepted. They have a restenosis of hardly 4 to 5% and a stent thrombosis of less than 1% with the best drug coated stents. And these were the structure which was made thinner and thinner with time. So further, with innovations, what it was thought that what better we can have than drug-eluting stent, then it was thought that if we don't leave metal within the coronary arteries, probably that would be best. We open the blockage with the balloon, put in a stent, and the stent should dissolve with time, so that the coronary is pristine clean after some time. So that's where this he came up with bioabsorbable scaffolds or bioabsorbable stents. This era came up, say, not long ago, hardly about, I would say 12 to 15 years back. We had these absorbable stents. It was actually called Absorb. It was actually made up of PLLA. Basically, it is a plastic material. That's what it was made up of. And it was put, and it would slowly, dissolve over next 2 to 3 years, leaving the artery totally clean. But the 5-year data which came up with these stents, when we compared with second generation drug-eluting stents, it caused almost 50% more heart attacks. It caused almost 70% more incidence of stent thrombosis. So that problem came up with this absorb stent. And what was the reason? The reason was it would not absorb cleanly, totally. You would find even after 5 years some struts hanging there of plastic material, which made it prone to have thrombus formation and heart attacks and thrombosis. So that's how this absorb went out of recognition. Though still we are having innovations in the form of different materials being used for making absorbable stents like magnesium and other things, but still we don't have a perfect absorbable material to be used as a stent. So these were the advances and the challenges which came up over time with balloon angioplasty, more abrupt closure, with bare metal stent, more restenosis, with first generation drug-eluting stent, more stent thrombosis, second generation drug-eluting stent, or third generation we call, basically it is finer material. All these they have now come down to the best thing probably for angioplasty is the drug-eluting third generation stent, which is considered the gold standard today. So along with stents, not only the material help, it was also the pharmacology. It came to be known that not only stents are important, probably the thrombus formation with the stent should be prevented by better these antiplatelet agents. And that's how we have now, better antiplatelet, the newer generation, ticagrelor, prasugrel, basically P2 white curve inhibitors. When given in junction with, aspirin, they prevent clot formation within the stents. The stent thrombosis rate being now coming lower to lower. Initially, it was thought to use both these agents for at least 1 year and then stop one of them and maybe continue aspirin after 1 year. But now it's been found that you could probably stop one of the antiplatelet agents even after 3 months of stenting, if it is required for some urgent surgery or anything, and continue with just one agent for lifetime, because we have a very good thin better stents now. So good antiplatelet agents help us again. So how has now recently this angioplasty advanced? So basically the advancement has, stents have remained as stents. So what betterment has happened over time? There's been technology development. We've been able to deliver stents to the areas where we couldn't take. We've been able to open up lesions which initially we couldn't do. The bifurcation lesions, like total occlusions, initially we would never open them, we would send them for bypass surgery. But now with better technology, better infra, I would say the catheters, the balloons, the stents, more flexible, all these things can be opened up, with the proper equipment, proper, learning, of course. And then came the improved protocols. All these, now procedures are done only when we have sound data. So what angioplasty did, it laid the importance of that there should be good trials before using any material, anywhere, or using or opening any artery. We should have good trials, and lot of trials over time showed us where we were wrong or where we were right. So angioplasty probably has the best, data from various trials to show drug-eluting stents doing good, especially in the area of acute heart attacks, where stenting has saved many lives, becoming the treatment of choice in any heart attack. And third is the dissemination of the best practice techniques. Now today, angioplasty is just not putting a metal stent and going home. Today we have techniques to see within the artery. We have imaging within the artery to see whether we have deployed, whether one is stent is required. Second is how the blockage is, whether it is calcified, non-calcified, it's soft, it is hard, and what kind of stent is needed. And third is the stent deployed properly? So that is what this imaging does. We have good imaging techniques to look within the coronary artery. And third is physiology assessment. A very important procedure has come up in the form of physiological, checking within the arteries. What that tells is basically what lesion we are seeing, whether we would derive any benefit from opening it. There are certain intermediate lesions. You must have seen very commonly people saying that this blockage 50% hai, this 60% hai, 70% hai. So whether to open it or not, we have now physiologically, we have a wire we put into the artery, and that tells us the pressure difference across the lesion. So that gives us an indication to whether open it or not. So this has become very helpful. I'll tell you how. So how these devices they improved, how we were able to do more, hard lesions, calcified lesions. These were the various devices which came up to treat hard and calcified lesions. Rotablation, of course, came up of 10 years back, where we were able to drill the calcified coronaries and open them up. So this was very important innovation. And now we have very high pressure balloons to open up hard calcified lesions. And this is the latest addition. It is a lithotripsy. You all know lithotripsy is being used for kidney stones and stones elsewhere. And now this mechanical energy is being used in coronary arteries to open up calcified hard lesions which were not initially opened up with any other thing. We have lasers now again to open up hard lesions, for fibrous lesions, for total occlusions. Laser is one thing which is helping us to treat these things. So now coming back again to imaging of coronary arteries. For imaging we have two procedures. We have intravascular ultrasounds and we have OCT, optical coherence tomography. These two they are used, they are delivered into the coronary artery to look into the coronary artery about to see the kind of lesion, and after doing the stenting we just see whether the stent is properly deployed, whether the sizing is adequate, we need to inflate it more, or so these are the basically best practice techniques. That first you look into the coronary artery, see the kind of lesion, decide the best stent to be used, and after deploying the stent, again put in this imaging wire to see whether the stent is properly deployed, and this gives the best results of coronary angioplasty. Physiologic guided, I have told you that you put in a wire and then see the pressure difference across the lesion. If it is significant, only then you open it. And how it's important, we can leave certain lesions, we can keep those patients on medical therapy, or in case of multi-vessel blockaging, these people can be spared of a bypass surgery. We can do the significant lesion only and leave the other lesions. So basically now this has come as a guideline, as a class 1 or class 1A indication to use all these imaging techniques before doing angioplasty. So what else we have latest addition to our armament, we have been able to do patients who have very poor heart functions, who are hemodynamically unstable. Earlier we would send them for a bypass surgery, and which almost 50% would be not subjected to surgery. The surgeons would refuse taking these highly unstable poor LV patients. And now what we do is we basically do all these patients of multi-vessel disease, left main disease, having very poor heart functions, and we have devices to protect the heart during the procedure. These are the various devices. We have intra-aortic balloon pump, the latest being Impella, which is a device which you put during the procedure into the LV, which pumps the blood from LV. So it helps in doing the function what LV has been doing, and you do the procedure becomes safe, and after doing the procedure you can remove this device. So all these assist devices they have made possible to do these complex procedures in complex patients. So this is the assist device which I have been talking about, and this is the latest addition to the angioplasty, is the robot assisted coronary angioplasty, still evolving stage, where the doctor doing angioplasty sits in a cabin, is not exposed to all the radiation, harmful radiation, and can do fine procedures sitting in his room. So to conclude, balloon angioplasty from just plain balloon angioplasty has developed to a new science where we have better stents to take care of these patients. We are doing complex procedures, we are doing complex patients with better and better results. And next 10 years are going to be more exciting, because what it's being thought that now with better anti-lipid agents, actually we may be able to remove coronary artery disease. So let's see when that happens. So till that time, I think this robotic procedure is coming up in a big way. And of course, all robotic procedures, they have their learning curve, take a lot of time to learn. And if they come up and when they come up, this would be great for the patients in general. Thank you.